Welcome back to Mysteries of Health Under Lens. If you are new here, I am a doctor currently completing my residency in pathology, and my goal is to help you understand what's happening at the microscopic level. Just a quick disclaimer before we begin. This video is a professional medical review intended strictly for residency preparation, lab analysis, and objective diagnostic education. I will be focusing purely on the high yield biopsy findings and underlying disease mechanisms rather than clinical management or treatment protocols. Please do not use this information as a replacement for medical advice. So, today we are going to break down measurable minimal residual disease in acute leukemia. Alright, then, let's get started.
Uh, so today we are going to discuss the measurable residual disease in acute leukemia. So today's presentation, they have majorly divided into 5 parts. The first part is what is measurable disease, why it is needed, or why it is needed, and what is measurable disease. Then what are the different techniques? Second part, briefly, and then the primary focus of this talk would be the flow cytometry as a technique in evaluation of MRD in BLL, then which will be followed by TLL and then the AML. So it's pretty complex and huge talk, huge presentation. The area people need years of experience to develop to standardize and to develop the expertise in this area, that is evaluation of measurable residual disease in acute leukemia. And similar to like acute leukemia, and measurable residual disease can be performed in any type of malignancy, and especially in all types of hematological neoplasms, which we treat, which the patient who receive the treatment. Okay. So let's move. Now, as I mentioned, we have what is MRD, why it is needed, methods. So if you look at this chart, this is called as Kaplan-Meier curve for the postgraduate, where you see the outcome. This is basically the outcome, and this is probability of event-free survival. And when we say event, means either the patient is relapse, progress, or death. Okay, so these are three outcomes. If the patient has disease already, which progress means increase the level of disease. Relapse means the patient went to the remission, means the disease disappeared and again came back. And death, of course. So these are the this. And so if you look at this figure, this Kaplan-Meier curve, this is from the for the ALL, that is acute lymphoblastic leukemia, and this is from AML. Now, if you look at it shows its curve shows the data from the year, right? So if you look at the first curve here, this looks like from 1962 to 1966, where they are documented 90 patients. And if you look at the years of follow-up, so you can see from 5 years to 45 years of follow-up after diagnosis. Now, if you look at these patients which were diagnosed, and 5-year survival was only 10%, right? Most of the patient, means 90% patient died within 5 years of diagnosis, which indicates that disease was very good, right? But then if you go to the next era, that from 67 to 79, it looks like approximately 35 to 40% patients survive 5 years. Still 60% patient couldn't survive. Then you go to 79 to 83, 50% patients survive. Then you go to the 84 to 91, 70% patients survive. And if coming to the close, now almost 90, more than 90% patients survive at least 5 years of the from the diagnosis. Right. The same way, if you look at the with AML also, the survival was very poor for 5 years in 10% of patients, and it is improved over a period of years. So what happened? What changed over a period of years? And we know that science progressed a lot. We had a lot of discovery of um drugs, right? Then management. But most important factor which contributed to the is that probably the therapy was inadequate earlier. Now we improved the therapy, right? Which could cure disease. Then a refractory tough disease. So many times the disease is tough and refract to the given treatment. So it's not getting killed or cleared from the patient. Or the second point, the next point is the leftover disease. So no matter even after giving the treatment, there is mild population of disease there, which is over a period of time, within a year or 2 year or over a period of few months, grow back and causes relapse. Right. So this is the strategy, because if you look at over a period of time, the survival improved from 10% survival to 90% survival. The reason is because we not only improve the drugs. For example, in ALL we have modification in treatment protocols, but in AML the treatment protocol for last 50 years is the same. But what changed is the method to risk stratify the disease. We started risk stratification of the disease. Based on the age, based on the genomics, based on the morphology, based on the immunophenotype, and most importantly, right now is the underlying genetics, based on which we started risk stratification. And based on the risk of the patient, if the patient has high risk, then the patient is treated intensively. If the patient is low risk, then patient were not treated, treated moderately, right? But ultimately, we want to know why the patient disease is coming back and why the patient is dying of the disease. Is the first answer was inadequate treatment. That means in a patient with high risk disease, you are giving inadequate treatment, which is not able to clear the treatment. In high risk disease, the disease might be refractory and the current treatment, given treatment may not be effective, so no need alternative treatment. Or most importantly, even after given treatment, in some patients, a leftover disease is there, residual disease, residual part of tumor is there, which eventually after a few months grow back, causing the relapse. And this disease is already resistant to the given treatment, so it's difficult to treat. But if then can we treat this patient intensively, right? That you can give the patient high intensivity treatment, but then what is the problem? See, if you give the patient intensive treatment, then the patient may get subjected to first is toxicity due to treatment. Then the cost, because the intensive treatment, you add more reagents to the treatment, that means multiple reagents or multiple agents you will use, so increase the cost of the treatment. Not only that, this intensive treatment also causes the other side effects, which increases the hospitalization of the patient, increasing the cost of the therapy as well as the therapy related morbidity. And this treatment, even because this toxic agent can also causes leads to secondary cancer. Okay. But at the same time, if you go give the less intensive treatment, there are high chances of relapse because the patient disease will not be clear. And that's why you need a balanced treatment. Balanced treatment means a patient which is standard risk or low risk disease can be treated with non-intensive treatment, because in this patient the risk of relapse is low. So it can be treated with non-intensive treatment, and thereby we can avoid the cost, toxicity, and morbidity associated with intensive treatment. But at the same time give the intensive treatment to the high risk disease, because if do not treat them intensively, then this patient will relapse and progress and cause the death or increase the morbidity. In those patients you need to give the intensive treatment. Now this type of approach is called the risk adapted therapy, because you are changing the treatment strategy based on the risk, whether it is high risk disease or low risk disease. Now, currently, the risk stratification is based on the major factors which affects the prognostication or risk stratification. Is one is age. We know that old age is high risk. or the age below 1 year is also high risk. So patient between 1 to 10 years are the best. But as you go more than that age, the patient, the disease become high risk. If the patient's age is less than 1 year, again it becomes high risk. Similarly, initial white WBC count. If the WBC count is very high, that becomes again high risk. Similarly, the subtype of acute leukemia, whether it is BLL, is usually is relatively better as compared to the TLL or AML. Then I, as already mentioned, genetics. If the poor genetics there are genetics factors which are associated with good risk disease, and there are genetic factors which are associated with poor risk disease. Okay. Now, despite of all these features, the one thing which is common is the response to the initial treatment and residual disease. Right? No matter what, everything comes to this. If patients is high risk because of the age, initial count, subtype, or the genomics, what it will result in the residual disease, because this patient high risk disease will, the tumor cells in the high risk disease will not respond completely or will not be killed because of the given therapy completely, and it will result in the in some level of residual disease. Now, if a patient has residual disease, higher residual disease, that patient has high chances of relapse. If the patient has very low residual disease, the chances of relapse is low, or it will relapse but at later time point of the life. So that is why one of the major important prognostic factor is the residual disease, and the current treatment approach is based on the risk of the disease, whether it is a low risk disease or high risk disease. Of course, how how do you assess the residual disease? Now you can assess residual disease by physical examination. If you know that the patient has big lymph node, so how much lymph node or the tumor size has reduced. If still you have some lymph node palpable, that means still there is residual lymphadenopathy or residual organomegaly is there, which indicate gross level of residual disease, right? Like physical examination or radiological examination, like PET scan. We know that PET scan is shows high active disease. If the disease is reduced, level is reduced, we can even look at the PET scan, and the PET scan will show the reduction of the disease. Then microscopic evaluation. We know the number of blasts on morphology. When there were 70% blasts, if they become 30% or 10%, we know that if still the blasts are there or the blasts are reduced less than 5%. And then comes the ancillary technique, that to identify sub-microscopic evaluation, because we know that morphologically it is difficult to identify the disease less than 5% or level is below 5%, because uh, even normal myeloid precursor or normal blasts are there in bone marrow. So in morphology you can get hematogones or myeloid blasts which can be normal, and therefore it is difficult to differentiate between just plain morphology and can tell us that whether the disease is there or not below, let's say, 5% of disease. Usually more than 5% it can be detectable, but even above 5% also it is difficult to differentiate between whether these are reactive increase in normal B cell myeloid blast or B cell precursor, that is hematogones, or this is a true leukemic disease. And then comes the role of ancillary techniques, which gives us the objective way to identify abnormal blast and to differentiate between the from the normal and even the low level disease, like below 0.1 or less than 1% of the blast. Okay. So what is MRD? What is measurable residual disease or minimal residual disease? The disease at its low level can be detected or measured only by the sensitive laboratory technique, which is sensitive than morphology, such as flow cytometry or molecular technique, is called as a residual disease, minimal residual disease or measurable residual disease. Just to show an example, let's say these red dots indicates tumor cells and blue dots indicates normal cells. Now, when patient receive intensive chemotherapy, that is called as induction therapy, okay, after at the end of induction therapy, most of the tumor cells are killed, but still you will have very few cells among the other normal cells are left, and these cells are resistant to the given treatment. So this is called as a residual disease and measurable residual disease because we can measure to the very low level So it's called as a measurable residual disease, depending on the sense technique which we use to measure the residual disease. And this is called residual disease, measurable residual disease. Now, why do you want to evaluate the level of residual disease? Can we just say, okay, it's present and absent, or do we need to quantitate it? Right now, the need first of all, I already told you, the need for identification is because we know that if a patient has a residual disease, that means that the residual disease is resistant to the given treatment, and this will eventually grow back and will cause relapse of the disease. And once relapse, then it is very difficult to treat such patient because these tumor cells are already resistant to the treatment. Now, there are multiple factors which contribute to the such type of high risk patient, including which are already mentioned, you know, including tumor microenvironment and the treatment given. Now, the levels of MRD is also important. The reason is because if the level of MRD is high, the chances of relapse, early relapse is high. So, for example, if MRD is high, then it will relapse within a year or half. If the MRD is low, then it will cause late relapse. If the MRD is further low, it may relapse eventually after some time, after a few years. But the current aim of the current treatment strategy is to bring the level of MRD so low that it will not relapse only. That means the patient's host immune system only kill them, the rest of the tumor cells, and it will cure the disease. So that is called a cure the disease, that you bring the level of disease at such a low level that the patient's own immune system or the body will take care and will not allow it to grow back, leading to the relapse of the disease, and that is called a cure. So this is the aim of the current treatment strategy, and that is why it is very important to know what is the level of residual disease, so that we'll have an idea if the patient can lead to the early relapse. Because at this level, if you have a disease level at this stage, that means you have to change the treatment protocol. And now we have better options in many diseases. For example, there are targeted therapies are available, including immune cell therapy, such as CAR T cell therapy, which if you give at this stage, work very well, leading to this stage, which can cause the cure of the disease. Okay, so and when we say quantifiable disease, you can always say, you can quantify disease where you have a diagnosis up to this level. So currently we reach the quantitation up to 0.0001%. That means one cell in 1 million cells. And as I mentioned, there are now based on the MRD, the protocols has been developed so that you can alter the treatment based on the level of MRD and the MRD positive and negative. So if the patient, this is for example added BL, this is one of the protocols, just to show an example where the treatment changes based on the MRD level. So you can see the time point 1 MRD, time point 2 MRD, and they change the treatment. If the patient MRD is positive, it is considered high risk, and the patient treatment or the intermediate risk. Here you can see the MRD level is low or negative. Here, if your MRD level is some MRD positivity is there, then consider it was considered as the intermediate risk, and when the MRD was high, it was considered high risk. This is one example of MRD based treatment protocol. So similarly, in India also we have treatment MRD based treatment protocol called the ICGL protocol. This is predominantly focused on the pediatric patients, where we categorized based on the MRD. If the MRD is positive at the end of induction, these are considered high risk. And if the patient is high risk, then they are divided into the two types of the arm treatment, and they are given the intensive treatment. If the patient's MRD is negative, then it is considered high standard risk, and they are given less intensive treatment so that we can avoid the treatment related mortality and morbidity. So similarly, even the AML also you have MRD guided protocol. So this is just example that the MRD is important not only for the risk stratification but also to modify the treatment strategy. There are multiple clinical trials which are going on, including in India. Okay, so do we have any question now, or shall I proceed? Do you have any question? Any student have any question regarding the concept of MRD?
No, sir. There is no question in the chat box.
No,
Okay.
sir.
So I hope that you understand what is MRD. MRD is nothing but the leftover disease which is there. And why it is important? Because it is a disease which is resistant to initial treatment, and it has very high probability to grow back and causes the relapse. Once relapse, it's difficult to treat, and then it is very difficult to manage the patient, and patient ultimately succumb to the disease. And that's why we can differentiate based on MRD which disease will, which patients will high risk and which patients are low risk. At the end of induction or initial treatment, if the MRD is negative, that means the patient, the given treatment worked very well in that patient because the disease completely disappeared, and there are very few chances or very small probability that the patient will relapse. That is one thing. Also, now we have MRD guided therapeutic protocols. If the MRD is positive above certain level, then we can change the treatment, and there are better options now where we can give the treatment based on the MRD status, and we can kill that residual disease so that we can improve and prolong the disease-free survival of patient. Okay. Now, what are the objective of any MRD analysis? One is to detect the residual disease in among or between other hematopoietic cells, because when we do look at the bone marrow or peripheral blood, the other cells are there, right? So first to identify that disease from the in between among the normal cells. Then the second objective is to quantify it. So what is the level? And third objective is to assess the representative of the sample, representativeness of the sample. What does it mean? That means if usually the bone marrow is the ideal sample for MRD detection or MRD assessment in acute leukemia patients. But if your bone marrow is dilute, it's not properly aspirated, there is hemodilution, that means it is not representative. In that case, if you give negative report, that means you're off, because that will be false negative because of the result of hemodilution. So that means whenever you are evaluating MRD in a bone marrow sample, we have three objectives. One is to detect the disease and in among the other hematopoietic cells. Then you have to quantify it, and then also one of the objectives to assess the representativeness of the sample. That means whether the bone marrow sample submitted for the MRD evaluation is representative or not. If not representative, then possibly you have to repeat the sample to identify and to call it true positive or true negative. Okay. Now there are two conceptual method of MRD assessment. One is based on the identification of proteins which were associated with the tumor cells. Okay. Now the proteins can be detected using a technique called as a flow cytometry, or broadly even can be used by IPGMER, right? Especially let's say lymphoma. But the sensitivity of IPGMER is low, so the better technique is flow cytometry. The other conceptual is to identify the genetic lesions or genetic abnormality, because we know the genetic abnormality is present at the time of diagnosis, and it will also present at the time of if it is still present at the time of MRD assessment, that means the residual disease is there, right? So conceptually, there are two. You can divide the MRD assessment technique into two parts. One is protein based, that is the protein or antigen present on the cell. So where we detect the number of cells present in this one based on the protein, and the other one is to presence of genetic abnormality or mutation or fusions or translocation which are there, which were present at the time of diagnosis. Okay, so these are the two principles. Now, the the one of the common the molecular technique is used is to look at the immunoglobulin T cell gene receptor rearrangement. That means we know that when the lymphoid cells mature, it undergo T cell gene rearrangement. And since the tumor cells are clonal cells, ALL cells are clonal cells. They have unique T cell gene rearrangement, and we can identify that T cell gene if we know that what was the sequence of T cell gene rearrangement in the tumor cell at diagnosis. We can follow that T cell gene rearrangement during the monitoring also, and that is called as a immunoglobulin or T cell gene rearrangement monitoring, that sequence monitoring. For that, we need to know what was the sequence at the time of diagnosis, so that we can follow the same sequence at the time of monitoring also. Similarly, the other method of detecting the tumor cell or residual disease is to detect the transcript. For example, at the time of diagnosis, we had BCR-ABL translocation or fusion, or gene rearrangement was there, or PML or NPM1 mutation was there, or any mutation, pathogenic mutation was there. If that was present after diagnosis, we can monitor the same fusion or mutation or translocation at the time of MRD monitoring also, using genetic techniques such as next generation sequencing or RQ-PCR. Okay, so here we follow the genetic abnormality. So the same way, so I was discussing about this different technique. Now there are, if you look at the different technique and if you compare them, each technique has some advantages and some limitations, right? So for example, flow cytometry, we have two techniques. One is the standard flow cytometry technique, and one is highly sensitive or next generation flow cytometry. Similarly, in molecular also, we have RQ-PCR, droplet digital PCR, and next generation sequencing, and they have its advantages. For example, let's discuss the advantage of flow cytometry. So flow cytometry is a rapid technique because it takes 2 to 4 hours for the processing of the sample and analysis of the sample if you take single sample. Right. So we can get the results within few hours. The second advantage is it's relatively cost effective. Okay. And then most importantly, it allows you to identify or evaluate sample quality. Okay, that means whether the sample was hemodilute or not in the same analysis. So when we are looking for the MRD in the same sample, you can look for the parameters which help you to identify whether the sample was hemodilute or not. Let's say by looking at other cells. If you want to look at immune cell profiling, to look at immune cell microenvironment, you can look at that also. Okay. And another advantage is that if there is a lineage switch between from B to myeloid, right, then that can be also detected. If there is some lineage or antigenic modulation, immunophenotyping changes is there in the tumor cell, that can be also detected by using the flow cytometry. Now, what is the disadvantage or limitation of flow cytometry is that, the one thing is that you need a live sample. You cannot store the sample and do it after a month or two. So you need live sample. Live means you have to process the sample before the cells degenerate, because the sample after 48 hours of collection, it can go under degeneration. So that means you have to process the sample within 48 hours. And if you have transported sample after which reached the laboratory after 48 hours, it can compromise your assay and results. The second is it also needs the expertise. Expertise means the analysis, because it depends on how expert the pathologist is to analyze the data using particular software. So that is another limitation. If you look at applicability of flow cytometry, almost in BLL and TLL, it can reach more than 90-95%. Basically, it go up to, if you have good adequate panel, it can reach up to more than 97 to 98% of applicability in ALL, and in AML also approximately 90%. Now, another method which I have mentioned is next generation flow cytometry or high sensitivity flow cytometry. Here the sensitivity is slightly lower, but here you can reach the very high sensitivity by acquiring millions of cells. Right. And in fact, next generation flow cytometry is based on some reference library created using the normal normal panel or normal cells, which also reduces the inter-observer variability. The similar, the cost is cost effective and is also widely applicable regardless of genomic profile. Okay. Now, what are the advantages of molecular method? So molecular method like qPCR, it is also rapid. You can get results in a day or two. It is also very sensitive. It has standardized guidelines already available. Okay, but here we need pre-treatment samples. That means we need to know what was the genetic abnormality at the time of diagnosis. That means if it is not done, then you cannot do the MRD. So that means you have to perform this assay both at the diagnosis as well as MRD. In flow cytometry, even if you do not know what was the phenotype of diagnosis at the time of diagnosis, at least in ALL, you can still do the MRD. In AML, you need to know what was the phenotype of at the time of diagnosis. But again, still without knowledge of diagnostic immunophenotype, you can do the MRD assessment by using flow cytometry. But here in qPCR, you need to know what was the genetic abnormality. Okay. Since the qPCR is applicable to only either particular repetitive mutation or gene fusions, and that's why it is applicable to a subset of patients. It's not applicable to 100 or more than 90% of patients. It's applicable to only few part of patients. Similarly, ddPCR or the droplet PCR is also highly sensitive. You need less standardization. It's qPCR need extensive standardization. dPCR does not need that extensive standardization. But again, you need pre-treatment samples where you know what was the genetic abnormality, and there is a risk of cross-contamination during droplet formation. Again, it's also still limited to the limited number of samples where you know the genetic abnormality. Nowadays, the more popular technique of genomic MRD assessment is next generation sequencing, where you can reach to the sensitivity, very low sensitivity, right? And many times even it can detect the clonal population which was not there from diagnosis, so you can track the clonal evolution. Okay, may not need in many cases the diagnostic phenotype. At least in ALL you don't need, but in AML you still need what was the genetic abnormality. But the problem is to go to this depth of sensitivity, you need to restrict the panel to the certain genetic targets, and thereby it becomes very expensive. It has higher turnover time. At least at current presently, it takes 3 weeks, approximately 3 weeks to give the data. Then also in many cases you need baseline genomic profiling and extensive bioinformatic infrastructure. You need the lab which has higher infrastructure, including bioinformatics as well as high-end computational power. But the advantage is it's also applicable to more than 90% of patients. Okay, so currently these two techniques are very popular, NGS as well as next generation flow cytometry or high sensitivity flow cytometry, and at some part, and at least in selective cases of a proportion of patients, even the qPCR or droplet PCR is used. Okay, so I already mentioned these techniques. Okay, so the droplet PCR, just quickly, in droplet PCR, what happens? You take a sample cDNA or DNA and you make the droplets, thousands of droplets, like usually 20,000 to 30,000 droplets, and in those droplets the PCR reaction takes place, and you detect the fluorescence as a result of PCR reaction, and you calculate the number of droplets where there was the reaction was that. That means the genetic abnormality or mutation is there present in those many of droplets, and you calculate the number of droplets in which the positive reaction was there out of total droplets, and that's how we calculate the presence of residual disease out of total DNA, or presence of present of tumor DNA copies out of total DNA copies, and that's how we calculate the residual disease. Okay. Uh, for next generation sequencing, you have to go through multiple steps. you have to first take the genomic sequences, break into multiple small genomic sequences. You have to, for that you have to go prepare the library. Then you have to sequence it, okay, by using called as a massive parallel sequencing, which takes place in the sequencer. And then once you have the data, it is realigned, and the data is realigned with the reference sequences, so all genomic sequences. It's little complicated. Probably it will be covered in the NGS technique in the subsequent of all, or already it has been covered in a different talk. So this today I'm not going to go into detail. And then using the bioinformatics pipeline, you identify the number of abnormalities or mutation or present in the sequence, and the number of sequences with this mutation divided by total sequences for that gene, and you detect, and that's how you calculate the residual disease or residual mutation out of total DNA copies, and you calculate the MRD. So this is MRD technique. Okay, I already mentioned this. The most advantage of I already mentioned that if you look at the turnaround time, flow cytometry is 3 to 5 years. For PCR, it is 2 to 3 hours. For the antigen receptor, for the droplet PCR also it is fast. If you look at within a day, and but NGS takes longer time. Okay, so that was about the different methodology. Any question now, or shall we proceed with the different diseases?
So I have a question. So how do we select the MRD technique if for other hematological malignancies apart from TLL, BLL, and AML, apart for others, how do we select?
Yeah, so there are multiple ways to select. First of all, availability, of course, right? So if some particular technique is not available, you cannot go for it, right? The second thing is the cost and the time duration. So, for example, if you are selecting a technique for risk stratification and there is no change in the treatment, then even you can select a technique which will take 2 or 3 weeks. But if you are changing the treatment, that means if you are doing MRD and tomorrow you want to change the therapy, that you need a technique which will give you result within a day or two, maximum 3 days. Okay, so that means first is availability. The second is the duration of time within which you want to have a result for the MRD, and third one is the cost. So cost effectiveness, if the patient can afford the expensive technique or not. Okay, so these are the different method way. Now the fourth way is, for example, the patient is affording, and you can wait. Then it comes for the which, for example, if you want to do qPCR or droplet PCR, then whether you have abnormality, genetic abnormality, which was available at the time of diagnosis, and can you track it. For example, if you are translocation, let's say PML RARA in APM, the qPCR is the best technique because you know that it can be monitored at very low level at different time points, and it gives you result within 2 or 3 days. So, and it is known abnormality which is there. Same way, if you have 821 translocation or if you have NPM1 mutation, then you can go for that technique. So, based on the availability technique and based on the molecular mutation. Now, if there is a mutation which is not traceable, then you cannot use the molecular technique because this fusion will be available. Let's say you have NPM1 MRD standardized in your lab, but it will be available only in 20 to 30% of patients because the NPM1 mutation is present only 20 to 30. So rest of the cases you cannot use it, right? So based on the what kind of disease you have, what kind of technique you have available, how soon you want to do, whether the technique available in your for your analysis, and then the cost. So these are the different parameters to choose the technique. Did I answer your question? Because it always depends on the type of disease, type of technique available, expertise available, duration of time, and how what your clinician want to treat, how we want to treat the patient.
Okay.
Okay.
Sir, there is a question in the chat box.
Yeah.
What are the method of MRD assessment in multiple myeloma?
Okay, in multiple myeloma, also you can use both. There are two types of methods available. One is NGS, the other one is flow cytometry. Both are very sensitive technique. Right now in India, at least, we do not have NGS based techniques standardized in myeloma. The other one is also mass spectrometry. So like using the M protein levels by using either immunofixation or mass spectrometry. So these are the three methods: using the serological measurement by using by detecting or by monitoring either M protein level or free light chain involved free light chain, which will be, which can be done by using mass spectrometry or immunofixation. The second one is the flow cytometry, where we can reach the sensitivity of 1 in 1 million cells. And third one is the NGS by using clonosec technique, which is already available, FDA approved, where you look at the IgG gene rearrangement which was present of the diagnosis and monitoring. So these are the three sensitive techniques which is used for the MRD monitoring in myeloma. And for extramedullary disease, PET scan. So even the PET scan can be used for the extramedullary, especially extramedullary disease, if you have remaining plasmacytoma kind of or remaining lesion in the bone marrow. So that is the fourth. So basically we can say four techniques: imaging, serology, flow cytometry, and molecular.
Okay, thank you, sir.
Okay. Okay, let's now I'm going to focus on flow cytometry, and we'll go first to the BLL, then followed by TLL, and but before that, I'm sure there are few are the students who probably not have couldn't attend the flow cytometry talk. So I'm going to briefly mention flow cytometry, how the flow cytometry works. So if you look at this is just an example of two flow cytometer which are commonly available in the clinical lab. This is from the company Beckman Coulter. This is from the BD. Now, what happens in the flow cytometer? You have lasers. Then we have something called the flow cell, and then there are the system optical system. So where we have different cells which go through the flow cytometer, and these cells are focus or force in front of laser in a single cell fashion. So then basically flow cytometry is a single cell analysis technique, and each single cell you monitor using different antibody which has fluorescence attached to it, which are detected by using the optical system present in the flow cytometer. Now, just to show you the principle, when I say single cell come in front of the laser, so what happens actually in flow cytometer? We have a cell on which we have different proteins present on the cell, and what we do, we put a specific monoclonal antibody which attached to that protein which is available present on the cell or inside the cell, and these antibodies, they have fluorochrome attached to them, a different fluorochromes. Now, when such cell come in front of laser, like so here, this different fluorescence light is separated from each other by the optical system present inside the flow cytometer, and we come to know that okay, which fluorochrome is positive, that means which antigen was present on the cell, and that's how we identify whether these are B cell, whether D cell, whether these are abnormal B cell, whether these are normal B cell, whether these are abnormal tumor cell, leukemic tumor cell, or these are normal B cell precursor, normal myeloid precursor. That's how we identify, because based on based on this principle. Now, detection of residual disease involves by flow cytometry involves three basic principles. One is to distinguish the tumor cells from the normal counterpart. Now, second is to distinguish the tumor cells from the other normal cells present in the sample. And third, to distinguish the tumor cells from the junk or debris. When I say normal counterpart, for example, in BLL, for B cells, the normal counterpart will be hematogones. That is normal B cell precursor. For AML, it will be normal myeloid blasts. For multiple myeloma, it will be normal plasma cells. And for CLL, hairy cell, mantle cell, it will be normal B cell which are present. Usually for CLL and mantle cell, normal CD5 positive, normal naive B cell. So that means first, what we have, the first principle of MRD detection by flow cytometry is to identify tumor cell and differentiate it from the normal counterpart. Counterpart means for BLL it is normal B cell precursor, for ML normal myeloblast, for myeloma normal plasma cell. To distinguish from the other cells which can look like the tumor cell. For B cell, other cells will be transient mature B cells or non-myeloid blasts, erythroid cells, B cell, T cell, other cells which are there. For T cell, normal T cell, for TLL, normal T cell, normal NK cells. Right? For AML, again, mature cells like promyelocytes, basophils, nucleated RBCs, monocytic precursors, mast cell precursors. So these are cells which are already there. So you have to differentiate them from these cells. And then, of course, I mentioned the junk and debris because what we do when we take samples, there will be some cells which will be degenerating and which will also interfere with your analysis. So you have to differentiate them also. So basically, when we differentiate, we analyze the MRD, we follow these three principles, and based on this principle, our analysis approach is developed. Now, when we have to differentiate leukemic cell from its normal counterpart, how do you differentiate? Right? I already mentioned you have to differentiate. Let's say BLL, you have to differentiate it from the normal B cell precursor, that is hematocrit, or in AML, normal myeloid blast, right? So how do you differentiate? Now we follow two principles for that. One is deviation from normal antigen expression. What does it mean? It means that all normal cells in any human being present all over the earth, they show a fixed maturation pattern with any protein present on the cell. So using this antigen expression, normal fixed antigen expression pattern, we know that we can differentiate the abnormal cell from normal cell, because abnormal tumor cell always shows some deviation from the norm, some abnormality from normal. So you take that as a principle. So deviation from normal antigen expression is first principle. The second principle is the aberrant antigen expression. When I say aberrant antigen expression, means lineage switch antigen expression. Means an antigen which is normally not expressed on normal cells, which is not expressed in normal cells but only expressed in tumor cells, that is called aberrant antigen expression. For example, let's say T cell marker in AML, or T cell marker in B cell, or B cell marker in AML, or myeloid marker in BLL, which is normally not expressed, but only tumor cell expressed. That is called the aberrant antigen expression. So first is deviation from normal. The second is aberrant antigen expression. So when you say deviation, under expression, loss of antigen, as represented in this figure, something which should be there is lost. Right? So loss of antigen expression. The second is overexpression. We know there should be 4 legs, but if there are 16 legs, so overexpression. The quantity of antigen is abnormally overexpressed, increased in its intensity. That's overexpression. Third one is asynchronous mismatch. Mismatch means a antigen which should be present on a particular stage of maturation is present in the other stage, because we know that hematogones, they have 3 stages of hematogones: stage 1, stage 2, stage 3. But a marker which should be present on the stage 3 present on stage 1. That means asynchronous mismatch there. That's called as it. So these are the 3 major principles which you use to define the deviation from normal. Now, if you have an aberrant antigen expression, that means I already mentioned unexpected. The antigen which should not be there at all, it is there. For example, if a dog hit on a bird, which you do not see, that is called as an aberrant antigen expression. This picture is to remember the principle. Now, to follow this principle, to adapt these 2 principles for the MRD assessment, you cannot rely only 1 or 2 markers. You have to use a combination of multiple markers, multiple antigens, so that you can study. Because A tumor cell can have certain markers, so similar to that of normal and normal markers, and only few markers can be overexpressed or underexpressed or so on synchronous expression, right? The same way, even aberrant antigen expression. In some tumor, you can have one antigen aberrantly expressed. In some other tumor, you may not. You may have other antigen expression, other aberrant antigen expression. So that's why you have to study which are the common antigens or common proteins which shows this deviation or aberrant expression, and then you have to add that in your assay so that you can study all these markers simultaneously. So usually now the current recommendation is to use at least 10 markers to identify these aberrancies in the tumor cell. Okay, so 10 and more than 10, because you have to use this marker not only to identify the deviation or aberrancy, but also to identify and differentiate them from the normal other cells which are present in your sample. Okay, do we have any question for the during the MRD? Any question if it is there?
Yes, sir. There is one question in the chat box.
Yeah.
If a patient has been detected with a known transcription, then only we can proceed with droplet PCR or other genetic methods except SGS. But at any time point, if there is no specific transcript, then we have to follow with flow cytometry data only.
Yeah, that is right. So if you are using molecular technique, then you have to know what was the genetic abnormality. And for droplet PCR or qPCR, RQ-PCR, then you need to know what was the transcript or what was the sequence also, so that you can monitor the same. For NGS also, this type of mutation was there at the time of diagnosis, and you will follow. Now, certain mutations which are usually or pathogenic, if they are there, it can be also considered as a residual disease, even they were not present at our diagnosis, or if even they present at very low level. So that, but it is important to know what was the at the time of diagnosis, so that you can track. In the absence of that knowledge, it is difficult to do the MRD monitoring. In those scenarios, the flow cytometry is more reliable and preferred technique.
Thank you, sir.
Okay, so now let's say what are the different steps in assessment of flow cytometric MRD? First is to select the panel, because now we are talking about flow cytometry. Now we have to select the markers for that particular disease. For BLL, we have to select markers which will be useful for DMRD, for TLL, for TMRD, and then. So the first step is the designing of panel or selection of the marker which are present, which can be there. Then the second step is to acquire the sufficient number of cells. That means you have to process the sufficient amount of samples so that you can reach the sensitivity. For example, if you want to gain a sensitivity of 1 in 1 million cells, okay, or 1 in 10 million cells, then you have to acquire so many cells, right? 1 in 1 million cells, that means you have to acquire millions of cells so that you can detect such a low level disease. Then analysis data, so analysis protocol. So that means you have to develop the analysis protocol using a particular software. For example, in Beckman Coulter we use Kaluza software, or maybe there is a Viva software, or other company you in Euroflow they use Infinisight software. So you have to use the software and you have to develop a protocol approach which you will use for the data analysis, and then you have to calculate. So then you have to develop a calculation method that you have to calculate the percentage of MRD out of all viable cells or out of all leukocytes present in the sample, so that you quantify the disease. So these are the major 4 steps. So now we will go through these 4 steps as well as how we are going to analyze the data. Now we are going to focus on BLL. Now, if you look at most of you probably have already this book called as a Henry's Laboratory Medicine, right? So you know already, right? So this is a figure which is there, and the people who is already aware done the MD Path or already using the flow cytometry for the MRD assessment, they are well aware of this figure. This is what this figure indicates in the color. Color indicates the expression. So when it's white means that is absent, and when it's red means present, right? So if you look at 45 in early precursor, it is weak. This you can see that the color is faint. That means the level of antigen is weak. And as you go, if it is becoming darker, that means the level of antigen means the antigen density is high. So we can differentiate that. What does it mean? That 45 is weak or the weakly expressed in early precursor, and when it becomes mature B cell, it becomes stronger. Now, if you look at TDT, we know that it is positive only in precursors. That is also CD34 also early precursor. We know the CD10 is positive in early precursor, but then it becomes negative at the time of as the cells become mature. The same way CD38 is expressed. CD19 is homogeneously expressed throughout the from the earliest precursor to plasma cell. CD20 shows variable expression at different stages. We'll see the different stages. So this is how the different antigen shows the different marker antigen expression. Now, out of them, these 45, 34, 10, 38, and 90, 19 and 20 is called as a backbone marker because they are used in all type of MRD, in all type of BLL MRDS. TDT is not used because it's a nuclear marker and it has standardization issue and it's not reliable marker to evaluate MRD. But 45, 34, 10, 38, 19, 20, these are called the common backbone markers. Okay, so as you can see, that means this 6 marker has to be part of your MRD assessment panel. When we say panel means number of markers when we are using simultaneously to detect any disease, that is called as a panel. Okay, so this panel has these 6 markers essentially should be there, and there are few additional markers you can add. Now, how they grow? This is just to show you. This is the animation. So if you look at these are the precursor. They gain when they mature. They become follow the sequence. This is 3D. On this channel you have CD34. This is 38, and then you have 27. So you can see that this is how they mature. So what we do, we look at we take all B cells and then we look for the maturation pattern using these markers. Now, you have to remember that although CD19 comes at stage 1 of B cell precursor, we know that there is there are 2 more stages even before CD19. Now, because we earlier from traditionally we are calling CD19 positive precursor, we consider stage 1 from CD19 positivity. What we have labeled the stage which is present before CD19 expression as the stage 0 and common lymphoid precursor. So we have common lymphoid precursor stage. That means the precursor lymphoid precursor coming directly from hematopoietic stem cell. The next stage is stage 0, which is before CD19 expression, but still it's a B cell precursor stage. And then you have 19 positive stages. Let's go stage by stage. Now here in these are the 6 figures which I'm going to show you how the B cell precursor mature. The blue cell indicates the earliest stage, that is common lymphoid precursor. That means this stage which is a part of hematopoietic stem cell. We know hematopoietic stem cell differentiate into the myeloid stem cell, myeloid and lymphoid precursor. So this is common lymphoid precursor from which you can develop T and K and B cells are developed. So this is the common lymphoid precursor, which is indicated by dark blue color. Now the next stage is to stage 0 hematogones. That means which is indicated by this light blue color. This light blue color is usually CD19 negative. And if you look at the stage, this CD10 also dim to negative. Let's focus first the hematopoietic stem cell. The common lymphoid precursor are 34 positive and 38 negative. You know that 38 is very important. Normally all B cell precursors express CD38, except the early precursors, that is common lymphoid precursor, it has CD38 dim to negative. Okay, they are 22 positive, they are 34 positive, they are 45 dim, they are 19 negative. Here you can see they are 19 negative, they are 20 negative, and they are 45 dim, and they are 10 negative. So 10 is also negative, 19 is also negative. Then which B cell marker is there? 22, 79 alpha are the B cell marker which are positive. 34 is positive, but 10 is negative, right? So this is stage 1. Then you go to the stage 0 hematogones. The stage 0 hematogones are the one which gain CD38 already. You can see CD38 is already there. They have some level of CD10, but still CD19 is negative. So CD19 is negative stage 0 hematogone. 45 is weak, 22 is positive, 22 is positive, 34 is positive. So 34 positive, 10 weak, 38 is moderate, but 19 is negative. Now, out of this, some stage, you can do some stage 0 hematogones also express 20. That means 20 expressions start appearing before CD19. Now, if you go to the literature, just few years back, before 3 or 4 years back, you will read that 20 comes after 19, but no. CD20 comes before CD19 expression. Okay, and some of the cells, and then comes CD19. So the 20 has very up and down its antigen expression. The sum of the cells which are CD20 positive, they die. Majority cells die and do not differentiate into the further, and very few, and then the cells which do not express 20 basically, then again they become, they gain CD19 and they mature further. Okay. So orange color here indicates stage 0, stage 1 hematogones. The very small population, there is early stage 1 hematogones. I am not considering that here for the sake of today's discussion. Let's say orange color stage 1 hematogones, because there are 2 stages. So stage 1 hematogone, here the CD19 appears. CD19 appears at this level of stage 1 hematogone. At this stage, 10 is bright, and 34 is also positive, 38 is moderate, 20 is variable. You can see the 20 is variable, 22 is also positive, but the level of CD20 is slightly, 22 is slightly lower than the earlier precursor, like stage 0 hematogone. Here you can see at this level 20 was higher, but actually it has gone down. So these arrows indicate the path of how the B cell matures from stage common lymphoid precursor stage 0, then stage 1, then the green population indicates stage 2 hematogones, where the 34 is lost. You can see the CD34 is lost. Okay, 10 is still there, but slightly lower. 10 is slightly lower, and 45 is slightly higher, but the rest of the marker is same. And then comes your transitional B cell and mature B cell, where you can see CD10 has become negative, 34, 38 has become negative, 22 become strong, 20 becomes strong, right? 38 lost, and 34 is also negative. So this is how the B cell maturation takes place. Now, it might be a little confusing, but this is how from stage 0 to stage 1 to stage 2 and mature B cell. So basically, B cell precursors start from common lymphoid precursor, then a stage 0, then you have stage 1, then stage 2, and then transitional mature B cell, transitional B cell and mature B cell. These are the same stages with a different other combination by using CD24 and CD81. So you can see CD24 starts also appearing on the stage 1 hematogone. Okay. 81 also start at stage 0 and then become, this is how it becomes higher in stage 1 and 2, and then ultimately goes down in mature B cell. So here you can see with 24 and 10 also how the maturation pattern takes place. So these are the different maturation pattern. Only small part of stage 1 is 24 is negative, where we can call stage 1A part of stage 1A. But you can see the some cells are directly maturing from here and becoming direct here. So it's not going. So there are two pathways for B cell maturation. One is getting 19 first and 24 later. The other one is getting 24 first and 19 later. Okay. Now, what is the use of this maturation pattern? Using this maturation pattern, what we do, we make the gates. So these boundaries, basically we make the boundaries among these, within these boundaries, all normal B cell precursors fall among these boundaries. So you take all these combination and make boundaries around them, right? Let's say I'll show you just to show an example. Let's say for this here, you make a boundary like here, like this, or you make boundary here like this, or you make a boundary like here like this, or here this. These boundaries called as the gates. Now you make such boundaries. The reason of this making such boundary is that when you have such boundaries, if any disease falling outside the boundary, that means it is not following this maturation pattern which it should follow. This is not following this maturation pattern which it should follow. This is not following this maturation pattern which is followed. That means the cells which are not following this maturation pattern, that means there is a deviation in the maturation pattern of some cells, and that cell possibly represent residual disease because it's not following maturation pattern, it's showing deviation in the maturation pattern. Okay. So that is called as a deviation from the maturation pattern. Now here I'm just showing you in what panel we used to use. We were using in Tata Hospital. This is 10 color. Now we are using 12 color. So where we have the markers which are there, you can see 10, 19, 34, 45, 38, 20 as a backbone marker. And we have three additional marker which comes an aberrant marker like 73, 86 and 30. Right. Some of the additional marker can be used is 81, 44, 58, 66, which can be also used for the as an aberrant marker. And when you use this pattern, you make a template. As I mentioned, you have to make a template based on this gate. So you can see this is a broad picture where I have shown multiple gates where this normal pattern fall. And what we do, the initial few plots is usually to identify B cells. So here in this pattern, here just to show you, we have identified B cell. You can see after a sequence of different plots, and once you identify B cell, then you plot against different combinations to see if the maturation pattern is there. And here you can see there are few cells which are following maturation patterns. There are few cells which are following maturation pattern, right here like this. And there are some cells which are not following maturation pattern, which are there here. So this is which are not following maturation pattern. In multiple plots you can see here, right here the ceridian is brighter than normal. Here the 20 is brighter. Here the 38 is weaker. You can see. So this is how we identify if there is abnormal residual disease which is there. Just to show you the closer example, this is just a case. You can see this was a case at the time of diagnosis where we had have the disease which is, so you can see the 34 was bright, the 34 and 86 aberrantly was positive, or 123 aberrant expression is there, right at the time of diagnosis. Now when this patient sample came for MRD, you can see there are a lot of normal B cell precursor which are following in the gate, which are showing the normal maturation pattern like this. Here these are normal, these are normal, but and we had a gate, but you can see the clear cut abnormal population which is outside this gate, which is matching with that of diagnostic. You can see the diagnosis the same way even at the time of MRD. So there was a disease which was there at the time of diagnosis and at the time of even MRD. And we can clearly differentiate from the normal. You can see the normal B cell precursor in orange, green and blue population, which is falling inside the gate, which inside the boundaries which were created based on the normal. And there were the residual disease is falling clearly outside the gate. So this is how you identify. This is another example. Here you can see at the time of diagnosis, there were CD38 down regulation, 58 overexpression, 123 overexpression, and even at the residual disease also it is there, right? Another example to just show you, there was an apparent expression of CD73 at the time of diagnosis, or ATCC at the time of diagnosis, and the same disease you can trace at the time of residual disease, but number of events is very few. You can see here, right? So this is. Now we had already published. Now there are many papers which is published in the literature from India also, where you can look at the disease, and this was high sensitivity MRD, where you could detect 2 abnormal cells in 1 million cells. So that type of sensitivity, you can see this is the same. You can see there are 16 MRD where we have detected in number of cells, in almost 4.6 million cells. You can identify 16 tumor cells, giving the a level of 0.0003%. Now also you can I mentioned that you can assess the quality of sample, where you can look at the viability. So viability using the viability dye like 780. So 780 is the nuclear dye which binds to the DNA, and DNA only which will bind to the dead cells. So you can see the dead cells. There are 80% of cells which are not binding with the 780. These are viable cells, and this 20, that means the 20% are dead. So viability of sample is 80%. Right? Then you can look at the hemodilution parameter. For example, in hemodilute sample, what we'll have, you'll have more neutrophils. You can identify neutrophil by using CD10 positivity, or you can look at erythroid cell by using CD36, or you can look at other myeloid blast present in the sample, because myeloid blast is not present in the blood. So if you have more than 1% of myeloid blast out of total mononuclears in the sample, that means your sample is not hemodiluted. If there is less than 1%, that means it is hemodiluted. Same way you can look at CD117 positive precursor, which is usually present only in bone marrow. If the cells which are present only in bone marrow becomes less, that means there is a blood contamination because of hemodilution. And this is one of the report you can see in MRD report from the Tata Hospital, where we have mentioned the expression level of different marker like CD10, CD34, or aberrant expression of CD71. And we also mentioned what was the level of disease, what was the number of cells we acquired, what was the limit of detection we could reach, means the sensitivity we could reach in this patient. So we can see we could reach the sensitivity of LOD of 0.0002 and limit of quantitation of 0.0008. And we also look at the other parameters which help us to look at hemodilution. And this is the one of the ideal report which you should use. And this report has been already published by the consensus recommendation, which the Indian consensus group, that is the Indian Flow Cytometry Society, the Cytometry Society, which has recently published the guidelines for BLLMR. Now, another method I already mentioned, which is followed in Europe, the Euroflow, is the next generation flow, which they use called as the APC, and by using a particular software, InfluenceX software, where they combine all this parameter and AP based on the APS technology, and using the software where all markers form, normal cells form one cluster like green cluster, and abnormal cell forms the abnormal cluster. So this is based on the principal component analysis. Okay, so this is what they do. They use all normal cells from the generating bone marrow. They normalize the level of expression of all markers, and anything which is going beyond 3SD is considered as abnormal. For example, here you can see for CD38, and which is indicated in the APS or the principal component analysis. Now coming to the next. Okay, before going to the next, is there any question?
Yes, sir.
Oh, yeah.
Yes, sir. There are a few questions in the chat box. Just
okay. Go ahead.
okay. Sir, the first question is, in the earlier graph, also the early immature B cells were labeled as CD19 positive and CD20 negative.
What is the question?
So question is, in the earlier graph, also
Mhm.
the early immature B cells were labeled as CD19 positive and CD20 negative.
The first figure you are
Yes,
talking
yes.
about, right? The one from the Henry's book.
Yes, sir.
See, that was old data. That's why I said that in last 5 years, we now since we have done more in-depth analysis. Earlier that we used to believe that CD19 positive are the first stage, but now we know that there are two more stages before even CD19 expression. That's why even CD19 negative you have stage 0 hematogone and common lymphocytes.
Okay,
So
sir.
as the science goes ahead in the future, we come to know more and more about the knowledge. So that was the figure which was from the 5 years or 10 years back information. Now with last 10 years, a lot of research has been done, and we know that these are the different two additional stages which are CD19 negative.
Okay, sir. Sir, the next question is, there any reason why we use particularly CD73 against CD19 to gate the B cells in VMRD?
Well, we do not use particular CD19 versus CD73, but we use a different combination. See, I told you that we have to know the asynchronous. What is asynchronous expression? So CD73 is not expressed in CD34 positive hematogone. Okay. In stage 2 hematogones, the level of CD73 expression is very weak. Usually, it is weak to negative. And that is why you have, when you are looking at the combination to identify whether the CD73 is abnormally expressed or asynchronous expression is there, then you have to combine CD34 with CD73 so that to see if the CD34 positive cells are positive for 73. If CD34 positive events are positive for CD73, that means that is abnormal, asynchronous, because normally CD34 positive cells do not express CD73. In CD10 also you have to look, because CD10, CD73 is weakly expressed in stage 2 hematogones. But in stage 2 hematogones, we know CD10 expression is weak. But if you have CD10 brightly expressed cells and CD73 is positive, that is also aberrance. So you can look at the combination. So the fruitful combination is to look at CD73 against CD10, CD73 against CD34. You can also look at CD20, because CD20 also changes from stage 1 to stage 2 hematogones and stage 2 hematogones. So the markers which shows variable expression from stage 1 to stage 2 or stage 3, that can be combined with CD73, because we know the 73 also shows variable expression from stage 1 to stage 3. So those combination is more fruitful in terms of detecting aberrance and asynchronous expression.
Okay, sir. Sir, there are few questions also I'm asking you. Sir, what is the minimum number of events required to call it MRD?
Okay, so usually, it depends on the what kind of, how comfortable you are there. You are to identify the abnormal cells in the background of other cells. So you usually, yeah, that terminology is called the limit of detection. Limit of detection means the number of cells which you can identify as a tumor cells in the background of other normal cells. So if you use a good technique, if you use 10 color flow cytometry, and if the properly standardized technique is used, then we can identify at least 20 events comfortably in the background of other cells. So that is limit of detection. Now recently we have done a multi-institute validation from the 15 different institute, and we could reach up to 15 events, where we can identify 15 events out of all other cells, right? But as a standard practice, you can take a 20 cluster of 20 events as a lowest level of sensitivity to detect in when you acquired at least, let's say, 4 million.
Okay,
Okay,
sir.
yeah.
Sir,
Next.
next is, what is the CD10% which suggests hemodilution?
Okay, so if you take a cutoff, there is no published, but we have done a study, and our laboratory data shows that if we use a combination of multiple parameters. One is CD10 positive granulocytes. If you identify all granulocytes, let's say high site scatter cell, out of them, if the granulocytes is less than 30%, that means the marrow is represented. If you have more than 30%, that means there are some cells which are coming from the blood. Okay, but that cannot be the whole parameter because sometimes patient can have neutropenia. So we then will look at the other parameter, that is CD34 positive cells out of total mononuclear cells. If CD34 positive cells out of total mononuclear cells, there is more than 1%, that indicates representative bone marrow. If less than 1%, that indicates hemodilution. The same way, look at the CD117 positive precursor, because CD117 positive precursor include myeloid blasts, include promyelocytes, include early pronormal blast. So if you take that combination, if it is more than 5%, that means the patient, the sample is not hemodiluted. But if less than 5%, that means the sample is hemodiluted. So if you have all these three parameters, then the 90% sample chances that the sample is hemodiluted. If out of one is there, that means there are 30% chances. If the two parameters are there, that means 60% chance. So that's why you have to use all three parameters. If all these three parameters qualify the cutoff for hemodilution, that means the 90% chances that you are using hemodilution. The sample is hemodiluted. If only one parameter is there and the other two parameters are not there, that means only 30% chances that the patient sample is hemodiluted.
Okay.
Yeah,
So next,
you can Google this. We have published ASH the abstract from the ASH last year. You can look at in 2025 ASH, and you will see the hemodilution parameters for BLL-MRD, and you will see the details of these parameters.
okay, sir. So next is how many events should be analyzed to do next generation flow MRD?
Yeah, so at least what we have recommended as a part of the consensus recommendation is at least 4 million viable singlet cells. That means you should have 4 million singlet viable cells to get the sensitivity of 0.0002 and reproducibility of 0.001%. That means the one log below the clinically useful cutoff. So clinically useful cutoff is 0.01%, but any assay should be sensitive enough to go at least 10 times below it. That means 0.001%. And for that, you have to acquire minimum 4 million viable cells, viable singlet cells to reach their sensitivity. And this is the recurrent recommendation of current consensus guideline formed by the Indian Flow Cytometry Society.
Okay. Thank you, sir.
Okay. So the next topic of the BMRD is briefly is, now we know that the patient of BMRD also receiving anti-CD19 targeted the CD19 targeted therapy. The problem is that when you target taking antibody against CD19 antigen present on the cells or CAR T cells which are present on the CAR T cells, what happens is the tumor can cause leads to this treatment can lead to loss of CD19 expression on the cells, on the B cells, on the B cell precursor, or normal B cell precursor. Now, whole our gating system of conventional MRD is based on the CD19 positive. But since CD19 is already removed or absent, then you have to develop another gating system, another panel, which is called as the anti-CD19 therapy-based MRD assessment. And for that, you have to use additional gating marker, which to identify B cell. And the additional markers, in addition to CD19, is CD22, CD81, 24, 10, and then also CD79 alpha. But look at this. You cannot use only one marker because one marker like CD22, because part of some of the cases can have deemed to negative expression. Like for example, 24% of cases can have deemed to negative expression of CD22. That means this will not be useful in such cases, right? So there are some cases that are heterogeneous. That means may not be useful. 24 also is similarly 12% of cases is negative for 24, and it is also positive in normal neutrophils, so it may not be the sole useful. CD81 also has similar kind of expression. That's why when you target CD19, you have to use the combination of these markers for getting. And even nowadays, they are not targeting only CD19, but they are also targeting CD22. So even CD22 and CD19 may not be available. In such cases, you have to use CD24, 81, and CD79 alpha, cytoplasmic CD79 alpha, as a gating marker for the MRD assessment. Okay. So this is one of the panel which we have. We have CD22, CD24, the CD781 as an our gating marker. In addition, in a patient where they are targeting both, then we have CD79 alpha also, and CD72 as a gating marker we are using. It is not displayed here, but that's how. Just to give an idea that in such cases you have to do additional marker for MRD assessment. And in such panel, the consensus guidelines says that you have to use minimum 12 color panel, which include these two additional markers, say 22 and 24. And we have to use additional gating strategy where you identify, you use this combination of 22, 81, 24, 34, and 10. So this we use all five marker as a combination to identify even the HLA-DR to identify B cell and to differentiate from the rest of the cell. So we use marker like CD66B and CD64 to identify, to separate granulocytes and monocytes from the rest of the cells, and then you take these cells and then identify the B cell among the rest of the cells, and then you do the analysis. Just to show you an example, here you can see this is an example after taking the CAR T therapy. In this patient, you can see the CD19 is completely absent. Only the tumor cells is identified by using 24 and 22. You can see the 24 and 22, but CD19 was negative. Right. So this is how you identify cells. The other aberrant markers were CD304, CD73. 38 was negative. So these are the aberrant antigens, but to identify disease, you need to know, you need to add additional gating marker like this. And this was the paper. Recently, it is published in the Cytometry. This was done, developed by the help of almost all major centers from the India, as well as there were few international experts as a part of this guideline. And this consensus guideline give the details, which panel, which marker you should use, how to approach analysis, how to standardize your instrument, how to process the sample, how to transport the sample. All details are given in this consensus guidelines. If you are standardizing MRD, please refer to this guidelines because it's a detailed document recently published in the Cytometry. If you cannot download, then you can email me or WhatsApp me. I can forward you this guideline. Okay, so this was about BLMRD. If there is any question on BMRD, or we can move to the TMRD.
No, sir, there is no question regarding this.
Okay. So this is TLMRD. Now let's go to the TLMRD. Now, before we're going to the MRD, we have to understand how T cell develop. Now we know that the majority of the T cell development happens in thymus, right? So if you look at the T cell, so stem cells first, we know the bone marrow has stem cell, common lymphoid precursor, and this common lymphoid cell precursor, this common lymphoid progenitor develops into the NK cell, they develop into the B cell, and some of the cells move to the thymus where they develop into the T cell. So the T cell development happens in thymus, right? Now in thymus also the T cell maturation takes place in three parts. One, there are parts which is cortical maturation of the T cell. That means the T cell matures in the cortex of thymus. Then they mature in the medullary part of thymus, and then become normal. They come into the peripheral blood. So in cortical part, usually the T cells are negative for CD4 and 8. They are called as a dual negative. In medullary part, they usually are expressed both CD4 and 8. They are called a dual positive. And when the cells become mature, the terminal part, they either differentiate only CD4 positive or they different only in CD8 positive. So this is how they mature. Okay. So you have double negative, double positive, then single positive. Single positive are only 4 or 8. And then they come into the circulation. Okay. So this is how the T cell maturation takes place. Now, you can refer to this paper which we have published, and these are the different markers we use for the T cell body monitoring. Now you can see there are almost 11 markers. The one marker which is there here, you can see we have CD3, CD7, then we have CD34, which is stem cell marker. We have CD5, another T cell marker. We have CD4, we have CD8, then we have cytoplasmic CD3. Okay, that means CD3, but which is present inside the cell. This is surface, means outside the cell or on the surface of the cell. Then we also have CD38, which is adhesion molecule. We have CD45, and we have 1656, which are NK cell marker. So we have these are the 10 color 11 marker panel, and I am going to tell you what is the importance of this. So in TLL-MRD, we start getting by using CD7 because CD7 is the commonly universally expressed T cell marker. Okay, so we identified T cell by using CD7. It is a sensitive marker because it is expressed in almost all TLL. It is very rare, 1 in 10,000 cells which will be CD7 will be negative. 10,000 cases of TLL which will be CD7 negative. Otherwise, almost 99.9% of cases will express CD7. That's why we identify T cells or we differentiate T cell in all bone marrow sample or peripheral blood sample by using CD7. So this is our getting marker, right? This is how we identify T cell. And then we remove the debris by using forward side scanner because we know the cells which are smaller than lymphocytes are debris. So this is how we start. Okay. But the problem is for CD7 positive cells, the CD7 positive cells also include other populations. We know that CD7 is expressed in mature T cells, right? We know the CD7 positive cells is also expressed in NK cell. We know the CD7 is also expressed weakly in earlier precursors of myeloid blast or some myeloid blast, especially the myeloid cells which develop into erythroid precursor. So the erythroid progenitors of the myeloid blast also express CD7. We know the PDC, that is plasmacytoid dendritic cells, also express CD7. And of course, our residual disease express CD7. So we know the CD7 is expressed in 5 types of cells, right? So once you identify cells, if we have 5 types of cells which are CD7 expressed, then what we have to do, we have to get rid of we have to identify and remove one by one this population. So we remove mature T cells by using surface CD3 because the mature T cells express surface CD3 and abnormal, that is T cell precursor, rarely express surface CD3. Even it is positive, it is expressed weakly expressed. So only 3%, 2 to 3% of total TLL express surface CD3, and that is also weak expression. So by using bright surface CD3 expression, we can identify mature T cell and remove. So this is removed. Okay, this is removed. Then NK cell, to remove NK cell, we use CD16 and 56. So using 16 and 56, that means the cells which are 16, 56 positive, we remove NK cell. For myeloid blast, we know we use cytoplasmic CD3. We know the myeloid blast do not express cytoplasmic CD3. So we remove myeloid blast by using cytoplasmic CD3. The digital handwriting is very bad. Then in the same way, PDC also is removed by using cytoplasmic CD3. So finally, if we remove all these 4 population, and if we still have CD3 population, CD7 positive population, that has to be a residual disease. So this is the approach This approach is called as the approach of exclusion. Basically, we identify all CD7 positive cells and we remove one by one all possible possibilities except for residual disease. We remove mature T cell, we remove NK cell, we remove myeloid blast, dendritic cells, so that finally we get TL body, and this is called as the approach of exclusion. Okay, so how it is done? As to show you, we first identify singulates, then we remove non-viable cells, and then we identify these T cells by using surface CD3. And the cells which are very high side scatter are removed because we know that these are doublets or non-specific binding of CD3 with high side scatter, because TLL does not show high side scatter. Now, once we have to remove mature T cells. So we remove mature T cells using surface CD3 expression. Once we remove surface CD3 expression, then we have CD7 positive cells. Then what we do? We remove the NK cell by using 1656. So all NK cells are removed by using 1656, and dendritic cell and myeloid blasts are removed by using cytoplasmic CD3. So because cytoplasmic CD3 is not expressed in PDC and myeloid blast, so they are negative, and NK cells are removed by 1656. Remember, NK cells also express cytoplasmic CD3. You can see here the cytoplasmic CD3 can be expressed in NK cells. So that's why you need a combination of 1656 and CD3. So using this approach, you identify all non-NK, non-myeloid blast, and non-PDC. So you get this population. Now in this population also, you use a combination of CD38 and CD5 to differentiate. The reason is because during cytoplasmic processing, some of the cells they lose surface CD3. So you identify those cells. You can see there are some cells showing short of surface CD3. That means they have weak expression of surface. Okay, so using a combination of CD4 and 8, you can identify normal cells, because normal cells express CD4 and 8 like normal T cells. Here you can see the one population is there, one population, and abnormal cells will have both negative and positive, dual positive 48 or dual negative 48, right? So you have to use a combination of 38 and 5. See, there are some cells which are 38 positive, 5 negative. This can be still NK cells which are 1656 negative, because 1656 can be negative NK cells. So you identify the tumor cells by using dual expression or dual positive expression or negative expression of CD4, right? Because normally you can see the normal T cells express CD4 and CD8, and NK cells expresses the expression of CD8 but no expression of CD4. So using a combination of these CD38, I, 4 and 8, you can identify abnormal cell population, and using 1656 you can identify other cell population. Just to show you an example, so this is diagnostic case. You can see in diagnostic case CD7 was positive, surface CD3 was negative, 5 was partly positive, 4 was double negative. You can see the 4 was double negative at the time of diagnosis, and even 34 was positive. Now, when the MRD came this patient, we removed normal T cell by identifying surface CD3. We removed NK cell by using 1656, and then we identified cytoplasmic CD3 positive population. And then we look at CD4 and 34 and 7. You can see this population was CD4 double negative, and subset of them was CD34 positive. So this is how you identify abnormal residual disease. And as I told you, any level of CD3 can identify, any level of MRD is of prognostic. You can see this is one of our data where we look at the largest data, one of the largest data of world, which is published here, a case of 269 cases. You can see the MRD positive cases had 5 times high probability of relapse as compared to the MRD negative. You can see that's why the hazard ratio was 5 as compared to the other features like ATP phenotype, mediastinal mass, hyperleukocytosis, even Harris age. Now, this is to announce, if you are interested in MRD, this year we are going to develop a consensus for TLL MRD in October on October 22nd, and this meeting is in Goa along with our annual flow cytometry meeting. So if you are interested, we in addition to Indian experts, we have 3 international experts, basically 2 experts from Russia, the one from the US and one from the Spain. We have 4 international experts who are going to be part of this consensus building. You want to witness. Here we are going to discuss which markers to use for TMRD, how to process TMRD sample, and we are going to develop a consensus recommendation for TMRD, for Indian consensus for this. If you are interested, please register. This is going to be on 22nd and meet along, and this is in the Goa. So, it's fun. Okay, so that was about TLMRD. Now I'm going to AMLMRD, and before going to AMLMRD, do we have any questions?
Yes, sir. There is one question. Okay, just there are a few questions in the chat box, sir. Just
Yeah, please go ahead.
sir, our question one is, are MRD cells only double positive and double negative? Can single positive cells can be MRD?
Oh, that's a very good question. See, majority of cases means approximately 55% cases. I'm talking about the data. We have collected data of 3000 TLL cases, and among them, approximately 55 to 60% cases are CD4 double negative. Another 35% cases are CD4 double positive. So that means using 4 double positive and double negative, you can reach more than 90% of cases. Now only 5 to 10% cases will be either CD4, 8, only CD4 or CD8 positive cases. And among them also you will have other abnormalities where you can identify. So to answer your question, majority of the cases are double positive, double negative. A small subset of cases are either 4 or 8 positive. In that cases, if you know the diagnostic phenotype, then you can focus. Based on that, you can identify. But usually these cases where you have 4 or 8 positive, the surface CD3 is also positive and it is weak positive. You can clearly differentiate bright positive. Now, one more additional marker which I have not discussed in this is CD48, which is also helpful. So in such cases, CD48 is very helpful because in leukemic cells, CD48 is negative and in normal T cells, CD48 is positive. So based on the CD48 expression, you can identify those cells also which are CD4, either CD4 or CD8 positive. But you can have up to 10% of cases where you can only 4 or 8 positive, and in those cases CD48 is there. So that's why CD48 is also one of the important markers for TLMRD assessment.
Okay, sir. So how to remove immature NK cells from the target population?
Yeah, so see, usually 16 and 56 combination will remove major of NK cell. But immature NK cell, it is very difficult because they have, there is no a single marker which is uniformly expressed in all NK cells, considered from immature to them. But you have to use the combination of multiple markers. So immature NK cell will express CD38, it will express CD48, it will express one of the NK cell markers, let's say CD94 or CD161, or there is new marker which is called as NKP80, and most importantly, it will be negative or CD5. So if you use a combination of these markers like CD38 expression, negative expression of CD5, positive expression of 48, so 48 expression, 38 expression, and negative expression of CD5. If you put this combination, then you can remove the immature NK cell. And of course,
Okay,
there will be CD4 double negative, or a subset of immature NK cells express very weak CD8 expression.
Okay, sir. So next question is, sir, could you please once again explain the use of CD38 versus CD5 in
Okay.
TMRD?
Okay, here. Now, as I mentioned, when you take non-NK cell, means when after removal of mature NK cell using 1656, after removal of mature T cell using CD3, after removal of myeloid blast and PDC using cytoplasmic CD3, you still have some cells which are immature NK cell, which is present in your kit. So if when you use CD38 and 55, what happens? The majority these immature NK cells will be CD5 negative. So you can remove by expression of CD5 these immature NK cells, and they are CD38 positive. So use this type of gate, you can look at this. So cells which are 38 positive and 5 negative, these are usually immature NK cell, and you confirm by using looking at the deemed CD8 expression. So subset of them are CD8 expression. You can look at CD48 in this panel. In this figure, I am not shown, but even CD48 can be useful for such of cases. So you use to identify. We can use to identify immature NK cell by using CD38. The another is to look at ETPLL, because ETPLL also express CD38 and 5 is negative expression. But in those cases, you have both 4 and 8 negative and subset of cases CD34 positive. So you can use 34, combination of 34, 5 and 38 for the identification of cases with ETPLL. Usually ETPLL has high level of disease, so it can identify. So you can use a combination of 38 and 5 for identifying immature NK cell as well as immature as well as ATPLL residual disease.
Okay, sir.
We can go into details, but it has to be TLL MRD focus session.
Okay. Sir, next is, do we need any extra markers in case of ETPLL?
No, ATPLL actually easier, because in ATPLL you have usually disease level is high, okay, and 34 is positive. A rare case of 5 to 6% of TLL also express CD56, but it will be. So combination of that is helpful. You using 5 negative expression, 38 positive, 34 positive, 45 dim is enough to identify ATPLL. But you must, I think, we strongly recommend using CD48 in your panel, because the only population which can confuse you with ATPLL is immature NK cell. So in that cases, CD48 helps.
So next is, as per your paper, how to detect MRD cells in shower check population.
Sorry. As per
your paper,
how
how to detect MRD cells in shower check population.
In
Shower check population. It was written by Dr. Prabhat.
No, I'm not getting in sorted population. You said it's sorted.
SHOWER, sir. Shower check population.
Okay, shower. Okay, the shower
check.
is simple, because see, I'll tell you, the shower is see, when you have the shower population, they usually show normal CD4 distribution. So if your normal CD4, for example, if this population is here distributed here, you can see the CD4 and 8 is distributed. So this shower will show normal CD4 distribution. So if you say, because normal, say in MRD you will have either 4A double negative or 4A double positive, or only 4 or 8. If you say 4 and 8 distribution like normal T cells, those are showers.
Okay, thank you, sir.
Okay, let's go to the next session. I'm sure it is 8:50, so I think we should finish a little bit, but I'm hoping it is going to go for at least half an hour. Okay, so AML-MRD. Now, AML-MRD, unlike BL and TLL, it is complex, because in AML-MRD, myeloid blasts differentiate into multiple lineages. It differentiates to the monocytic lineage. It differentiates to granulocytic lineage. Means even the myeloid blast has a compartment of blast, monoblast, granulocytic blast, erythroid blast, megagrocytic blast, precursor of dendritic cells, precursors of basophil, precursor of mast cell, right? So combination of so many cells are there, even the precursor compartment. And because of that, it becomes complex. So you have to use such a panel where you can identify all these normal precursors, and then you have to identify disease by differentiating tumor cell, by differentiating precursor from all these blasts, right? And so that's why you need a differentiating pattern. Now, to follow this, how the myeloid blast matures, I'm going to take you through that. So if you look at any myeloid blast precursor, uh, we have, when you look at stem cell, the stem cell can be divided into three parts. We know that how stem cell mature, right? The stem cell mature, the first part of stem cell is hematopoietic stem cell. right? The second part, so stem cell, hematopoietic stem cell are CD90 positive. Here you can see, and CD38 negative. So they were CD38 negative. These are hematopoietic stem cell, earliest stem cell. They mature from here. They mature to something which we know terminology multipotent progenitors. Multipotent progenitor, right? So in this, they lose CD19, but they still CD38 negative. Now from here, they mature to called as a common myeloid and lymphoid precursor. Common myeloid and lymphoid precursor. So using these two markers, you can differentiate into three populations: hematopoietic stem cell, multipotent progenitors, and then common myeloid and lymphoid progenitors. Okay. Now, if you take these cells, which are common myeloid and lymphoid progenitors, and get them with CD45RA and 33, you can see you will have five different clusters. We have one cluster which is 45RA positive, the another cluster which is negative for both. There is third cluster which is 45RA positive but 33 moderate positive. There are another cluster which is here. You can see the 33 positive but 45RA dim to negative. So using this combination, we can identify five clusters. Now, what are these five clusters? The cluster which is 45RA positive is common lymphoid precursor for 33 negative. The cluster which is negative for both 45RA and 33 is erythroid megakaryocytic progenitor. Erythroid megakaryocytic progenitor. The cluster which is 45RA positive but 33 weak is called as a plasmacytoid dendritic cell precursor. And the cells which are positive for 33 but 45RA is variable, these are granulocytic monocytic precursors. Okay. So that means if you have enough markers in your panel, then you can differentiate these normal myeloid precursor differentiate into different lineages. Okay, when you take these and you put another markers, you can identify their maturation pattern. You can look at, you have cyan blue color, which are 22 positive, which I have mentioned. These are common myeloid precursors. And these are the cells which are common lymphoid precursors, which we have seen in our B cell maturation pattern. The earliest stage of myeloid precursor, that is common lymphoid precursor. Okay, which are 45 RA positive, 22 positive, and 33 negative, or any myeloid marker like 117 negative or 13 negative. Okay, so this is the another population which I have mentioned, myeloid, the erythroid megakaryocyte precursor. These are predominantly erythroid progenitors. These are 117 positive but 33 negative. Here you can see the 33 is usually weak. You can see they lose 33 like here. So they are maturing from the precursor level to here in this direction. Then we have granulocytic precursor, which are 33 positive, nicely. Granulocytic monocytic precursor, they are 117 nicely positive here, right? Then we have dendritic purple color cell population, which is 123 bright here and 33 positive, but 117 negative. They have gone like this. Okay. Erythroid precursor also shows bright CD71 expression. They also show CD36 expression, which is erythroid precursor, right? And they also have HLA-DR. So you can see even erythroid, myeloid, all precursors are HLA-DR positive. Now some cells of these will grow, lose CD117, the HLA-DR, and some cells will become bright 117. These are mast cell precursor and these are basophilic precursor. These are basophil, these are mast cell precursor. So this is how the cells will. The reason I'm telling you, because if somebody is standardizing the AML MRD, you have to know this maturation pattern. Otherwise, there will be abnormal tumor cells where at the time of diagnosis, which are 33 negative or 117 negative or HLA-DR negative, you know, so they will match, mimic and overlap with this normal precursor, and someone can call them as a false MRD positive. Just to show you the maturation pattern, you can see these are the maturation pattern. You can see. So I think for the sake of, I'll just keep this part. As I mentioned, I was mentioning, you know, some of the cells which are maturing toward basophil. So here you have basophilic precursor, These are dendritic cell precursor. Both are 123 positive, and you have to know even 123 is aberrantly overexpressed in tumor cells. So you have to know the normal maturation pattern toward dendritic cell toward basophil. In fact, people are now publishing this data that's showing that okay, what is the quantitation of this population. So for that, you have to, like we usually, you can use a single tube which has 16 color, or you can use 12 color multiple tubes or 10 color multiple. If you are using 10 color, you have to use three tubes. Means the three different panels. If you are using 12 color, you have to use 2 tubes, and if you are using 16 color, then you can use single tube. Now, what are the purpose of these different markers? We know CD34 and 117 is to identify precursor cells. Then we have 45 and 38 to identify stem cell. The reason is because even abnormal stem cell represent residual disease, and the tumor cells shows many times loss of CD38. Then we have 13 and 15 to identify myeloid differentiating, the cells which are differentiated granulocyte lineage. We have markers which can identify erythroid maturation, like monocytic maturation, like 64, 33, 64, and 14. Then we have PDC and basophil differentiation by using 123 and HLA-DR. And then we have to also add 36 also helps you to identify erythroid precursor. And then we have to add markers CD9, let's say just CD19, 7, and 56, which is aberrantly expressed in the AML. So this is a combination. So either you use all these markers in one tube, or you can put these markers in 2-3 tubes with some common backbone markers. And this is another, you can just to show, I'm just saying the hematopoietic stem cell, multipotent cells, and common common progenitors, which shows maturation pattern. So if you put at 38 and 34, it will show this type of maturation pattern. You can see here. So this is maturation pattern. Okay, if you combine 13 and 117, you will see one population towards myeloid precursor, one population which moved towards the normoblast, that is erythroid precursor, and then one population will move towards B cell precursor. You can see the B cell, as well as some will go to even the monocytic precursor. So monocytic precursor will also lose CD13 and 117. So they will fall here. So with using the combination 13 and 117, it will show this type of maturation pattern. If you combine 33 and 19, you will see there are B cell precursor which are 19 positive, and monocytic and myeloid precursor which will be 13 positive. The same way, if you combine 64 and 13, you will see some cells are becoming monocytic precursor, some cells using promyelocytic precursor. If you use 36, you will see some cells maturation toward erythroid precursor. Right, same way, if you use 203, you will see some cells showing maturation toward mast cell and some toward basophil. If you combine 123 and HLA-DR, you will see the differentiation toward PDC as well as basophil. So using this combination, you can look at the maturation. And once you know that any tumor population which is not following this maturation pattern, that means they're showing deviation from normal maturation pattern, and those are abnormal cells. So that's how, using this combination, you can identify differentiation from normal or deviation from normal pattern. That is also called as a DFN pattern of maturation, or the approach to find out abnormal residual disease. But remember, to identify abnormal residual disease, you have to know this maturation pattern. And just to show briefly what kind of initial grading strategy we use. So we start with mononuclear cell gate. So we identify mononuclear cell by using CD38 because it separates granulocytes very well. Once you identify mononuclear cell and exclude all granulocytes, because we know the disease does not have high side scatter, then you take these cells and identify progenitor region by excluding CD45 bright cell population. And then once you have these progenitor cells out of mononuclear cell, then you form 3 clusters. You identify 3 clusters. One is 34 positive cells, one is only 34 117 positive cells, and one is both negative cells. So once you know at the time of diagnosis if the tumor was 34 positive, you focus on this population. If you know that the tumor cell at the time of diagnosis was 34 positive negative but 117 positive, then you focus on 117 positive compartment. And if you know they both were negative, then you focus on the third compartment. So after removing granulocytes and mature lymphocytes, selected progenitor cells are then divided into three compartments: 34 positive compartment, 34 negative 117 positive compartment, and 34 and 117 both negative compartment. And then you look at the population, and then you look at the. Now, even if you look at 34 positive compartment, you know the 34 positive compartment will also have hematogones. So you have to remove hematogones by using the combination of 19 versus 33, 19 versus 117, and 19 versus 13. And you use the combination. So any cells which is 33 negative, 117 negative, and 13 negative, and 19 positive are B cell precursor that you remove. And you also remove some debris which are CD14 positive, because usually because universally CD14 is not expressed in myeloid blast, and you can remove the non-specific monocytes which is non-specifically binding to CD34. And once you have that, then you look for their maturation pattern. So you look at all different combinations we have already discussed. In 34 negative 117 positive population, also you have two types of major population. One will be promyelocytes, which will be 33 positive. The other one will be pro-normoblast, which will be 33 negative and 36 positive. Right. The same way, the pro-normoblast will be 13 positive and 15 positive, and the erythroid cell will be 13 and 15 both negative. You also look at the dendritic cell by using 123 positive cells, basophil using 123 and HLA-DR. So cells which are 123 positive and HLA-DR negative are basophil, and which are bright 123 positive HLA-DR bright are dendritic cells. So using this combination, you can look at this population. Just to show you some example of abnormality, you can see the OR expression. You can see the OR expression of 34. These are normal level of CD34, but look at the abnormal population of CD34. So OR expression of CD34 is considered as an abnormal. Same way, abnormal OR expression of 117 can be used as an MRD detection aberrancy. The another way to look at the underexpression, you can see the underexpression here. Normally CD38 should positive like this, but here you can see the CD38 is lost, which is aberrancy. You can identify, you can call it an aberrancy and abnormal. Then here you can normally, you know that CD13 shows this type of maturation pattern, but loss of 13 completely again is aberrancy. Then we know that normally the 13 positive cells are not there. Only very few erythroid precursor, erythroid myeloid precursor, erythroid megalytic precursor express CD7. But if you when you look at the combination of 13 versus 117, these are normally this population which is 7 positive, 13 positive is more than 7 positive and 13 positive, right? So this is usually more. This compartment usually more than this compartment. So if you have the other way around, that means 7 and 13 positive population is more than 7 and 13 negative population, then that means this is aberrancy. So 7 aberrant expression. Then aberrant expression of 19 or 56 bright expression, not weak. Remember, normally also you can have weak expression up to here of study 56. So a strong expression, homogeneous expression of 56 is abnormal. Aberrant expression of 19 is abnormal. Okay. Just to show you this is one of the case. You can see the 36 where 36 we identify 34 positive population by using OR expression of 34 abnormal blast, right? Okay, so this is another example of 19 positive or loss of 13. There is another example of aberrant pattern. See, normally this should be the pattern, but there is aberrant pattern, right? There is overexpression of HLA-DR is there. Okay, so this is just a data in pediatric. You can see the AML MRD positive patient has high risk, high possibility of relapse as compared to the MRD negative. So this is just one of the data with hazard 3 times higher. So this MRD negative population, the MRD positive population is 3 times higher risk of relapse as compared to MRD negative. Now that was about AML MRD. Any question about AML MRD?
Yes, sir, there are a few questions.
Yeah.
Sir, question is after CD5 versus CD38 gate, as per your paper, you divided the entire target population in 4 parts
Yes.
and then individually check CD45 versus CD7. Can we directly plot it in single gate rather than 4 different gates?
You can, but it is better to look the population separately because then it will give you more confidence. You can do it one population, but then because see usually fortified slightly dimmer will be also present in NK cell also. The NK cell can also show weak expression of CD45. It is usually fall between the blast and mature T cell. So it's good idea to, if you look at this population separately, make a practice of that so that you can identify what is abnormal and what is normal.
Okay, sir. So
But
next is
you
how
should
to
have
differentiate.
48. So, yeah, 48 will help. What is? Yeah, go ahead. Go ahead.
The next question is how to make promyelocytes.
Okay, normal promyelocytes. See, when you're talking about APML, usually the flow cytometry is not that sensitive because you can detect abnormal promyelocyte up to 1%, maybe up to 0.5%. Below that, it is very difficult. But up to that also you can identify. So normal promyelocyte has a strong CD15 expression. It has CD11A expression. It has CD18 expression, and they are CD9 negative. So I am talking about 4 markers now. 15, 11A, 18 and CD9. So 3 markers are positive in normal promyelocyte and 1 is negative, CD9. But if you get in abnormal promyelocyte, it is the other way around. That means CD15 is down-regulated, weakly positive. CD18 is lost, CD11 is lost. And CD19 is overexpressed or positive. So that's how you identify abnormal promyelocyte from normal. I'm talking about abnormal promyelocytes of APML. In case of dysbiosis, it's a different thing. You have to look at the maturation pattern.
Okay. Okay, thank you, sir.
Okay, so now what's new in MRD by using flow cytometry? Now something called as a full spectrum flow cytometry. This is new. What is new is that up till now we used to look at only a peak of fluorochrome. That means if any fluorochrome will show this type of fluorescence, right? This type of fluorescence. So in conventional flow cytometry, we were only measuring this peak of this peak of fluorochrome. The rest of the fluorescence was not measured. Okay, and this was identified. Now in full spectrum flow cytometry, what we are using, we are detecting complete spectrum of fluorescence, and because all fluorochromes have different fluorescence pattern like this, so that you, based on their full spectrum, you can separate the signal from all fluorochromes, and this allow you to use multiple fluorochromes in the same channel. So in a standard fluorochrome, for example, in blue laser, you can identify 5 markers. In red laser, you can identify 3 markers. In violet laser, you can identify 5 markers. But in spectral flow cytometry, you can identify, even blue laser, you can identify up to 12 markers. In violet, you can measure up to 8 or 9 markers. In UV, you can measure up to 10, 12, 12, 15 markers. So spectral flow cytometry, because you are measuring spectrum instead of a single peak, you can identify up to 50 markers in same flow using same 5 laser instrument. That means now in a single tube, you can identify 50 or 40 markers on the same cell. And that is, it is called as a high dimensional flow cytometry or full spectrum flow cytometry, which can be used, which usually use In a complex assay like AML MRD, where you want to look at all this maturation pattern in the same cell, as well as to evaluate the immune cell monitoring, where you want to look at the T cell subset, B cell subset, NK cell subset, dendritic cell subset, especially to if you want to look at the immune cell profile in depth, and it has strong significance in many infectious diseases as well as the immunological disorders, where you want to look at in depth of all these all these parameters. So that is called as full spectrum flow cytometer. And this full spectrum flow cytometer, when you want to study the conventional analysis may not be helpful, so you have to use advanced flow cytometry, where you use the more clustering based algorithms can be used for the such type of analysis. So that is one thing is new. Other is the site of base. So uh, where what we where the cells are lysed, but the protein, once the protein bound with radioisotopes tagged to the antibody, particular antibody. So they are radioisotopes which are tagged to the particular antibody, um, uh, and which binds to the protein present on the cell, and these cells, uh, the cells are evaporated in very quick time, um, and those are monitored. So, but those site of kind of techniques are rarely used. The more is used is flow cytometer, full spectrum flow cytometers. Now they are available almost majority of major centers of the world. They have spectral flow cytometer. Many centers in US and Europe, they have full spectrum flow cytometers. Even our center in Tata Hospital, they have flow cytometer, spectral flow cytometer. But the majority of centers are focusing using spectral flow cytometry for research purpose, mostly for immunological etc. Now the people are working on developing assays in AML MRD. We have recently standardized AML MRD, 22 color AML MRD by using spectral flow cytometry, and simultaneously few more centers in Europe also have developed this assay. The next new thing is AI, that is artificial intelligence based enabled flow cytometry data MRD and analysis. There are multiple studies which has at least three studies has been published. The one is from the MD Anderson for VLL, the other is for AML from the Sylvia Freeman group from UK, and then from one from the CLL from. So there are groups. So you use artificial intelligence because this is repeated task. They use. They define using artificial, because all the data flow cytometry can be converted into CSV file, that is Excel file, and based on the data, they train the model for the normal population, and then they train the model for abnormal population, and they use this model. This model can be helpful in majority of the cases, but remember, it is helpful up to 90 to 95% cases, not in 100% of cases. So it can help in certain amount of cases up to certain level based also, but this is under trial. There are some publications done. The only limitation of this AI-based analysis is that you have to have homogeneous MRD panel and homogeneous instrument setting. The moment your instrument setting changes, the moment your panel changes, you have to develop new AI-based model which can be helpful. And that is the reason, although it is being developed in one center, it is not reproducible to other centers. Now people are working in a model where it can use multiple centers to harmonize. So if we harmonize this MRD data to multiple centers throughout the India, let's say, then we can develop AI-based model which can be helpful for the such kind of AI-based MRD assessment. So here you can see, once you are AI-based, you can use the UMAP-based the clustering algorithm, where you can identify different cluster. You can see the different cluster, different colors, and then you can identify residual disease, because residual disease fall into the different cluster. But remember, this type of approach can go up to certain level of sensitivity, and to go below the higher level of sensitivity, you have to really develop a good algorithm, which people are working on. Okay, so coming to the advantage of flow cytometry MRD, we know that it is a popular method. It is widely available. Almost all oncology center or Majority of the lab it is available. Okay, it is shortest TAT, you can get the result within 2 to 4 hours, maybe 6 hours maximum. It is highly sensitive, you can detect even 1 cell in 1 million cell or 2 cell in 1 million cell. It does not need, it do not need, there is no need of diagnostic immunophenotype except in AML. Even AML you can do it, but it helps if you know the diagnostic phenotype. It is widely acceptable. It is applicable more than 95% of cases of BLL and TLL and approximately 90% of AML. It is cost effective. The EQA, the international quality control is available, both national and international. So EQA in India, with Tata Hospital, we run the EQUAS program for MRD, for all types of MRD, BLL, TLL, AML, myeloma MRD, and now we are going for even NABL accreditation for proficiency testing. Only disadvantage is that you need to be done within 48 hours to 36 hours of sample collection, and another is you need to develop you need a proper experience and standardization. In fact, standardization is needed in any lab, any technique, any method like genetic method or NGS. Also, you need very good standardization. But here you also need some expertise for the MRD assessment. So to summarize, another important point is, we for MRD assessment we need first full bone marrow for MRD assessment, because to avoid hemodilution, it needs to be transported in especially room temperature at cold temperature approximately 10 degree. Should not freeze the sample. For MRD assessment, the sample should reach within 48 hours of the collection. The treatment details and diagnostic phenotype should be available, because that is, you need to know whether it is a post-induction, post-consolidation time point. Then you should use at least 8 color, but it is recommended to use 10 and more than 10 color. Person, the lab should acquire more than 1 million for AML MRD and more than 4 million cells for ALL MRD, and for more than 5 million cells or 10 million cells for myeloma MRD. And you must assess the sample quality for the reporting. Okay, some points to remember is MRD is the disease which is left after treatment, but it is always limited by the sample, because you are taking a sample from, let's say, iliac bone. That doesn't mean it represents whole bone body, right? You can still have a residual disease somewhere in other part of the marrow, in other part of the body. That is why this MRD, one sample MRD, because of the sampling error, you still can have MRD negative patient which can relapse, because there is a sampling error. We are taking a sample, small sample of bone marrow, not all, and that is why it may be, you may miss. There might be some patients which are MRD negative but still relapse. Okay. And sometimes you can have the change in the residual clonal evolution, the residual disease. The clonal evolution, if you are using molecular techniques, and if you do not use the proper panel of NGS panel, then you may miss if there is a clonal evolution and there is additional mutation or the other mutation. The flow cytometry can help you, but you are at the same time you have to also remember that even immunophenotypes can show some deviation, some modification, so you have to aware of that. Now, this whole thing we have published in a chapter of book. This book is recently published. If you are interested, this chapter is also available, I think, for the purchase. And this book is very interesting book. This book is published by the US authors. Other than so most of the authors of this book are from the United States. But this whole disease spectrum of acute leukemia MR disease is in detail. It has been written by our group from the Tata Hospital. Okay, so with that, I will stop, and if there are any question, I'm happy to do this. This is our group of flow cytometry in Tata Hospital. Thank you. Any
Sir,
question? Yeah.
yes, there are two questions. First one is, if we have to start doing TMRD reporting as per your paper gating strategy, do we need to standardize it? If yes, then how can we do it?
Now, yes, of course, you have to standardize all standardization. You have to run at least 10, 20 normal bone marrow samples or post treatment B or AML MRD samples to look at the how your panel is working. You have to add all these markers in your panel and so to see their distribution and their expression and everything. Once you are comfortable, then you have to do the spiking experiment. Spiking experiment means you have to take normal bone marrow sample, spike with the known diagnostic sample. You put very small amount of tumor cells, let's say 0.01% or 0.1%, and see you can identify with this panel. Once you are confident about that, then you this is called as standardization validation process. And once you are confident you have standardized the assay, then you can start MRD.
Okay, sir. So next is, what is the significance of shower check gate since it shows normal distribution? Can it have MRD cell?
No, so see, once see generally shower cell. What does mean by shower cell? Shower cell means the cells which has lost some surface area due to processing. Because you see when we lyse and we are doing permeabilization in TMRD assessment, so there is a extra damage to the cells during permeabilization. So that causes loss of some protein antigen level of surface area. So it becomes weak, right? So in that case, but usually surface area 4 and 8 distribution is normal. So in case if they are shower, you will have normal either 4 and 8 both type of population present. In MRD, you will have both negative or both positive. So using the 4 and 8 combination, you can identify residual disease.
Okay, sir. So thank you so much, sir. It was an excellent talk, and thank you for sharing your knowledge with